This meeting is being recorded.
And not a stretch that it is about medications. So my name is Sara Dugan. I'm a mental health pharmacist and faculty at Neomed. And what I was asked to talk about today is best practices in prescribing medications. We're going to focus a little bit on mental health medications, but some of the general principles are even broader reaching than that and would apply to all medications. So 3 objectives that I hope to focus on today. So list the general principles. We're going to start with this. It's going to be the structure for the presentation, and that's what we're going to end with. We are going to describe some medication considerations that are a little more specific to pediatric and adolescent patients, and then identify some questions that maybe you'd be able to use that could be helpful in supporting your patients as well as their family and caregivers with their medication regimen. So our general principle, as I was looking at this, we could do best prescribing practices for each specific diagnosis. I wanted to take a much more general approach because I think a lot of these concepts go beyond just a specific diagnosis. So the main framework is we want the medicine to go to the right patient, the right drug, the right dose, the right time. So we want to make sure all of that is set up not only to avoid errors, but really to get the best outcome that we can from the use of medications. So how might that work? We're going to break that down section by section, and we're going to start with the right patient. So initially, who are we treating? What is it that we're trying to accomplish? Are the concerns about symptoms, are they coming from the patient themselves? Are they coming from a parent or caregiver, from a teacher, from a therapist? Are they coming from the healthcare provider? Have they identified something where they're saying, hey, we need to go after this when maybe that's not a priority for the patient or for the family? So really kind of thinking about not just who's getting the medication, but where are we getting some of this information from? Because especially with mental health, it's really important that we get feedback to ensure that what we're doing is improving the overall functioning of the patient. Other things to keep in mind, goals and expectations. So if we're treating a child for attention deficit hyperactivity disorder, what is the goal that the family is expecting from this medication? If it's to control some of the hyperactivity so they can essentially sit still and pay attention for the most part throughout school, so that they're able to develop some relationships or some friendships, maybe that they're able to participate in team-based sports, then that may be a realistic goal. If the goal is going to be to improve GPA, so to make the student's grades be much greater, maybe we're not working in the right direction, because it may not really help move a student who's a C or D student all the way up to an A student. Sometimes there may be a mismatch there. If it's due to missing work, then it's a possibility. But if that's really the only outcome that they're looking for, then it's possible that there's going to be some disappointment. I think also related to the patient is, we're going to come back to this a couple of times, is making sure that we know that how there is improvement. If this is something that's important to the patient, are we going to be able to show that we're moving in the right direction, especially if they're not able to put words to some of those symptoms? And then the last piece is probably the most functional, but is that medicine actually getting to the patient? Are there adherence issues or adherence barriers, or is the medication going somewhere else? So really kind of considering some of those concepts as we're starting to build what's going to be the medication regimen for the patient. So right patient, getting the right drug. I think one of the places that we could start, where I initially was going to start, is what are we treating? So what is it that we're going after? Depression may look completely different. You may have 10 people that you're following, all of them have depression and they all look totally different. So just saying we're treating depression really may not be that helpful a description. So identifying what are target symptoms that they've isolated, maybe that they have lost interest or pleasure in things. Maybe it's an appetite issue. Maybe it's a sleep thing. What are those specific things we're going after to determine whether or not this has been effective? For some of the conditions, depression being one of them, we may have a menu. So we have a handful of different medicines that we could choose from. So trying to determine which one would be the best fit. Yes, sometimes we can use pharmacogenomic data, but that's not always going to tell us this is exactly what we need to use. So other information that may be helpful for you to gather or to share would be what's been tried in the past. Have we used something and it was effective? Let's go back to that. Did we use something and it was a complete failure and actually made things worse? That's good to know because we want to avoid that. Are there other medical conditions? Are there medications? Things that could potentially interact with some of that pool of antidepressants that we could potentially choose from. That'll help us narrow down which one would be the right medication for this patient. Ideally, we would like to see a medicine that works quickly. That's not always going to be possible. So is the patient able to wait? If the anxiety, if it's an anxiety disorder, many of our anxiety medicines that work long-term take some time to work. Is that okay? Or is that anxiety so much that the patient's having a lot of issues with other behaviors or other symptoms where we need something that's going to be a stopgap measure to really help acutely? In that instance, maybe it makes sense to have multiple medications. One that we use right now to kind of give us a little bit of a buffer and some breathing room until we can get the long-term efficacy to work. But ideally, if we can, we'd love to manage medications lowest doses possible, which we'll get to, but only one medication if possible. And then adverse effects. So are there going to be things that are make or break? I had a patient who had Asperger's, and she was not willing to take anything that caused dizziness. So anything with dizziness that may impact blood pressure was a non-starter. She was not going to take it. And if she got dizziness from a medicine, she would start refusing. So identifying that means that we may be able to limit what some of our options are to get the right drug that's going to be a fit for that patient. So let's look at an example. So Jonah, a 16-year-old male, I did this generically. So recently hospitalized with psychosis, had some paranoia, was threatening neighbors with a baseball bat. There are reports of auditory and visual hallucinations, seeing shadows and hearing individuals telling him that the neighbors are out to get him and his family. Okay, so in a case of psychosis, maybe suspected early schizophrenia, we would have a pool of options. So antipsychotics can treat that psychosis. It can help with the paranoia. It may help with some of those hallucinations, but there's a whole pool of these medicines. So how would we get started? Well, initially looking at the ones that are approved. So which ones have evidence to say that, yes, in this population, so in teenagers who have psychotic symptoms, we've seen benefit with these medicines. Makes our list just a little bit smaller. Sometimes we have to go outside of that and we use things off label, but at least to start with, we want to make sure we have a firm evidence base. Then we can pull in some of those other factors. Are there other medical conditions? Are there other medications on board that we want to avoid interactions? Are there some of those side effects? Maybe he's not sleeping, so we would prefer an agent, olanzapine, quetiapine, acenapine, something that might be a little more sedating to help him sleep. Maybe sleep is a non-starter. He doesn't want anything that makes him dizzy, drowsy, so maybe those are going to be the ones that we stay away from. So that's how you're going to start to see those pools of medication classes get whittled down to identify the right drug. With that in mind, we try to match them up as best we can with indication. Some of the medical conditions are going to go right to medications first line. Attention deficit disorder, aside from your preschool patients, this may be something that we use pretty quickly. Very effective. Patients tend to tolerate them relatively well, so you would see medications used early on. Some of our other medications on the opposite end of the spectrum, maybe we're not going to medicines right away. Insomnia, I think, is a great example. Sleep hygiene, I think all of us could improve our sleep hygiene. So maybe looking at some of those things before we start to prescribe or utilize a sleep medicine would be in our best interest. And then there's quite a few that may fall right into the middle. So the agitation, aggression, the self-injurious behaviors, How much of a problem is this? What is it that we're seeing? If there's extreme agitation or aggression, maybe that particular youth is unable to use some of the other skills that they have. So maybe we need medicine to help build a buffer for them to be able to describe what's going on, what's upsetting them, to be able to try to use some of those other skills. Or if the severity is relatively high, maybe we want to try psychotherapy or cognitive behavioral therapy for anxiety or depression. But if those symptoms are really, really severe, maybe we need the medicine on board as well. So not always automatically jumping to them, but recognizing that there's going to be situations where we may use medicines earlier on than not. But just because it gets added on board doesn't mean it's cast in stone and we're never making changes. So this is really just a reminder that we can see side effects early on, we can see side effects later on, and we need to make sure that we're balancing any adverse effects with efficacy of the medication. Is it doing what we're hoping that it'll do? Also, for some of these kids, it may have worked initially and later on it doesn't. So just revisiting, is this what we have on board the right drug for the patient right now? Because just because that answer was yes 2 years ago doesn't mean that answer will always be yes. And I think continuing to ask that question is really important. Moving to right dose. So having the medicine on board is great, but if we're not using enough or we're using too much, that could be a problem. Overall, the mantra tends to be start low, go slow. So starting patients at a low dose and then slowly moving the dose up. We want to use the lowest effective dose. So what's going to give us some benefit in preventing exposure to a lot of adverse effects. One word of caution though, just because we start low and go slow, we still have to go. So if we're getting some improvement from anxiety medicine, but we never really bump the dose and there's still some anxiety symptoms, before we add something else on board, let's make sure we're getting all that we can get out of this one medicine. So really making sure that we've optimized the dose if we can. If there's side effects, then that may not be possible, but really trying to maximize our monotherapy approach. Other than dose, we also have to think about how does the medicine get in? So not just how much we're using, but how are they able to get that medication into their body? We've had quite a few new formulations come out, which is exciting. This is really a reminder that we've got lots of options. So if taking medicine is an obstacle for a patient or for the caregivers, maybe there's something else we can do. Patients who may have trouble swallowing, liquids or solutions aren't the only option. We may be able to dump out the contents of a capsule. Maybe we can go to a tablet that's a chewable or an orally dissolving tablet so that they don't have to worry about having to swallow their medications. So we've got quite a few options that we can think about, both short-term and in some cases more longer-term options. So just kind of a reminder that sometimes the medication is right, the dose is right, but it's really more of a matter functionally of getting that medication into where we need it to work. In addition to dose, last piece is the right time. When are we giving the medicine? When do we need that effect? If we have a patient who has attention deficit disorder and they wake up and their hyperactivity and impulsivity is worst in the first 30 minutes when they get up, maybe we need a medicine that they're taking so it's in their body when they wake up, as opposed to being at the lowest levels in the morning and having to take a medicine and then wait for those concentrations to build up. So are we able to match those? How long has a patient been on medicine? How long should we expect them to be on medication? So all of these things are just pieces to keep in mind. And for you, you may also have some really helpful feedback on the regimen. The regimen sounds great, but if it's too complicated, they're not going to be able to do it. So we want to keep that in mind. So right patient, right drug, right dose, right time, but kids are not just little adults. Their brains are still developing. They may not have the communication skills. Some adults don't have the communication skills to be able to communicate what's going on. So really ensuring that we're watching for things. Symptoms may look different. The effects of medications may not be what we expect. We expect something to be sedating and it makes them really excited and amped up. So kind of keeping that in mind, that these are an entity unto themselves. Ideally, the best prescribing practice is to put the patient first, to make sure we're paying attention to them, because medications can be an important piece of the puzzle, but likely they're not going to be the only thing. So hopefully that's helpful to get the right medicine to the right patient at the right dose at the right time. And with that, I'm going to stop my share and I'll turn it back over to you, Renee.